the Victoria 1 study was sort of unique. So I just first want to call out this is a large phase 3 randomized open label clinical trial that was conducted in two parts. It was essentially two studies within one. Both the studies were testing a very novel, potent inhibitor of the PI3 kinase AKT mTOR pathway called gedatolisib. This is a very unique inhibitor because it hits all four PI3 kinase class 1 isoforms, as well as mTORC1 and mTORC2. And previous attempts to do that in the past have been associated with too much toxicity. So the first study we presented and published already was exclusively in patients whose tumors were wild type for the PIK3CA mutation. They didn't have that driver mutation. And the data we presented at ASCO were for patients whose tumors were essentially detected to have a PIK3CA mutation. And they were randomly assigned to one of three treatment arms, either a triplet of gedatolisib, palbociclib, and fulvestrant, a doublet of gedatolisib with fulvestrant, or alpelisib plus fulvestrant. The randomization was also a little unique. It was a 3-to-3 to run randomization for the gedatolisib triplet and the alpelisib fulvestrant doublet, which is the control arm. Fewer patients were enrolled in the gedatolisib fulvestrant arm. That was more of an exploratory arm. And the primary endpoint was progression-free survival for the triplet versus standard of care for PIK3CA mutated breast cancer at the time the study opened, alpelisib fulvestrant. And what was shown was a very statistically significant and meaningful improvement in progression-free survival with the triplet versus the standard of care alpelisib doublet. The median PFS was 11.1 months, which to our knowledge is the longest PFS seen in a phase 3 study in this disease subtype after a CDK4/6 inhibitor. And the hazard ratio is 0.50, meaning a 50% reduction in the risk of progression or death. So that was the main outcome, the sort of big bang. I thought it was also really exciting that the objective response rate seen with the triplet was actually 48.9%, which also I think is the longest objective response rate or highest objective response rate we've seen in this particular patient population, and is, certainly clinically meaningful. We also saw in the exploratory analysis of the doublet of gedatolisib fulvestrant versus alpelisib fulvestrant a very similar improvement in progression-free survival with gedatolisib, a median PFS of 11.3 months, almost exactly the same seen with the triplet where palbo was used, and about a 50% reduction in the risk of progression or death with a hazard ratio of 0.51. Another way to kind of look at how much medicine was getting into the individual patients is by looking at the relative dose intensity. And I think that was really interesting because the relative dose intensity for gedatolisib fulvestrant was 100%. And if you compare that to alpelisib, it was 81.7%. When we publish this, we'll get into the nitty gritty of each drug in the triplet and doublet, but I can tell you palbociclib dose reductions did occur due to the neutropenia that we see with palbociclib. And so that brought the RDI of the triplet down to 93.3%, which is still really good when we're talking about a regimen like this. Because this study had the alpelisib fulvestrant doublet, discussions with regulatory authorities based on the alpelisib label compelled us to have a cutoff of an HbA1c of 6.4%. The monitoring for patients on alpelisib was more intense for sugar, for glucose. I think we probably could have patients with higher HbA1cs treated in the real world, and I think that'll be a very interesting study to do, is looking at the safety of gedatolisib in diabetics, which is a not unsubstantial patient population. So I don't think we need to be watching glucose doing the finger sticks. If geda is approved, I don't think we have to be as intense in terms of monitoring. We do, however, need to watch for stomatitis. All the patients on this study received prophylactic mouthwash, swish and spit steroid mouthwash from the outset. We saw over 60% of patients have some level of stomatitis, although with the doublet, only 6% had grade 3, and we didn't see any new events really accumulate after cycle 3. So it tends to happen quickly. So I think we should be monitoring our patients early on in those first 2 cycles closely and making sure they have good oral care, and are communicating if they're running into trouble so we can address it.